Thank you for joining, everybody. As you all know, my name is Georgia McIntosh, and I'd like to welcome you all to our third quarterly Morbidity, Mortality, and Improvement Grand Rounds. This is especially something that we're really looking forward to, as we have a number of guest panelists that I'm really excited to have present today. So our Morbidity, Mortality, and Grand Rounds presentation today is entitled Medication History and Reconciliation, Pearls and Pitfalls. As you all know, this is something that is near and dear to my heart, as well as many of our quality directors and folks that just do this work each and every day. So hopefully we'll be able to get a sense of some of the challenges, but also some of the solutions and improvements that we've made here at VCU. To introduce our panel of panelists, we have Dr. Kristen Miller, who's an associate professor in the Division of Pulmonary and Critical Care Medicine. She currently serves as the Director of Safety and Quality Improvement for Pulm Critical Care and is the Medical Director for the MRICU, not a small task. We also have Dr. Bhardwaj, who's an associate professor in the Division of Cardiology. She is the Vice Chair of Operations and the Medical Director for Safety and Quality Improvement for the Division of Cardiology. And if that was not enough, she currently also serves as the Medical Director for Adult Echocardiology and Inpatient Cardiology, so has a lot of free time. Dr. Miller and Dr. Bhardwaj, for anybody that doesn't know, serve also with many of our joint initiatives that span both the MRICU and the ICU and the cardiac ICU, and really work together to improve patient care and communication across both really critical divisions. So we appreciate their work. Sorry, we're having a little technical difficulty. Oh, there we go. As an additional treat, I'd like to introduce Dr. Silvia Munoz-Price, who, as many of you know, is our new Chief Quality and Safety Officer for the VCU Health System. We're really excited that Dr. Munoz-Price agreed kind of last minute to give her overview of quality and safety for the health system. So she will be talking to start us off. If those that are not aware, Dr. Munoz-Price arrived here in December of 2021. She is a professor of medicine and is nationally recognized as an expert in infectious diseases. She completed her training in Lima, Peru, and received her PhD from the University of Miami, and has been serving as the enterprise epidemiologist at Froder Health at the Medical College of Wisconsin for a number of years. In her role there, she oversaw infection control and prevention across multiple hospitals and over 30 clinics. And was able to raise their Vizient status to a top 5 ranking by decreasing infection rates, a feat that is not without, I'm sure, a lot of work and consternation. And prior to her work in Wisconsin, she was the medical director for the Department of Infection Control and Prevention at Jackson Health System in Miami, Florida. So we're really excited and privileged to have Dr. Munoz-Price in our Department of Medicine and serving in this role. We also have Dr. Peter Zolas, who's a PharmD and inpatient staff pharmacist here at VCU. Dr. Zolas graduated from UNC from the Eshelman School of Pharmacy in 2012. He completed his PGY1 residency at Togus VA Medical Center in Augusta, Maine, and then was hired here at VCU as an inpatient pharmacist, and quickly was able to rise to serve one of our needs, which is as the lead on the medication history service. So later in this talk, we're going to hear a little bit about that service and what our pharmacists are able to provide. So as you all know, the goals of our Morbidity, Mortality, and Improvement Conference are to learn from medical errors, complications, and unanticipated outcomes, to engage faculty and learners in a discourse surrounding any critical incident or near miss, and to identify any system errors rather than identifying individuals. And really the goal is to increase transparency regarding any organizational improvement efforts. This is not new. Really, the goal is to put yourself in the viewpoint of the provider involved, and really to use I wonder statements rather than they should have. We maintain confidentiality, so in this presentation, you'll see no identifiers for patients or those involved. And really the goal is to help discover any fixes and ways that we can improve care for our patients. The learning objectives for today, we're going to provide an overview of our focus on quality and safety from Dr. Munoz-Price. The second piece is to define the challenges for a timely and accurate best practice medication history, as well as learn what a medication reconciliation looks like for our patients. And then we're going to learn about our available resources to assist with the best practice medication history. We'll hear from Dr. Munoz-Price for her vision for about 15 minutes, and then jump into our case presentation. And then lastly, hear about the health system response from Dr. Zolas. And we have no conflicts of interest to disclose. So at this point, I'm going to turn it over to Dr. Silvia Munoz-Price to give her thoughts about quality and safety for our health system.
Well, thank you, and hello, DOM. It is my pleasure to talk to all of you. And as I have mentioned to Dr. Syme and to Dr. Behrman, I am really looking forward to be part of DOM soon. So what I'm going to be talking today with you about, as Dr. McIntosh just said, is high level, what is it that we're doing right now? So next slide. Next. So one of the main concerns that the leadership had at the time I was hired was the number of serious safety events that the system was observing among our patients. And of course, that is my number one priority, to figure out how to prevent them. So during the first few weeks, what I did was observe the process of how the system evaluated each SSE. And basically what has been happening up to recently is when an SSE happens, a serious safety event happens, everybody reacts. Everybody reacts. And there's an RCA in some cases that happens, a root cause analysis, and an action plan that occurs. And even though the action plan sounds and looks good, the compliance with those interventions in many cases, it's questionable. And then a new SSE happens again. So what I have pushed during the last few weeks, the leadership to do is to change the way that we do business. So instead of using a whack-a-mole approach to how we handle SSEs, one-off, looking at SSEs as patterns of events over time. And there are some events, there's some patterns that happen more frequently. And among those ones that happen more frequently, the way to prevent them is to really understand why they're happening, right? So understanding the why, and then tailoring interventions that are system-wide in order to prevent those diseases from keep happening. So going from a vertical approach to a horizontal approach. Next slide. Next. And, you know, when I said the whack-a-mole approach, that's a reactive approach. You wait for the event to happen and you react. Another event happened and you react. And if you think about it, the push that I'm making is to change that reactive state into a more systematic phase in which we implement interventions that prevent the events from happening in the first place. Eventually, in the next few years, hopefully, we will move into a proactive state in which we don't even wait for that event to happen. We are able to look at near misses or before a near miss happens, right? And we fix our interventions accordingly. Unfortunately, we cannot do that yet because we have too many serious safety events. So we need to move into systematic first. Next slide. Medication errors are one of the most common system safety, serious safety event errors that we have. Next slide. And because of that, medication-related activities or goals are one of the main priorities of my department. So if you see the first column there, you have medication reconciliation. And by medication reconciliation, I'm talking about medication history, the process, right? That starts when the patient's admission is decided and ends when medication reconciliation is actually as a task is done. I'm talking about all that process that includes medication history. So that process in the inpatient area, that process in the outpatient area, and revamping in close collaboration, the structure, right? Redesigning the structure of the medication safety committee so that Dr. Chouinard and her team are actually able to make magic happen. Next slide. I think I don't have a slide. Nice. Yeah. So the last thing that I'm going to say is that medication reconciliation, that process, right, of medication history, medication reconciliation, it has many chapters, many buckets. So we have to start somewhere. And we have decided to start in the emergency room. So right now, what is happening is we are mapping that process of all patients who end up being admitted through the emergency room in regards to medication reconciliation, from the time that they walk to the ER until the time the medication reconciliation actually happens as a task. And we're figuring out, okay, that is the baseline. What is the optimal state? And how do we fill that gap, right? And we'll, as I said, we're starting in the emergency room, but we will move into different ways that a patient is admitted into the hospital. Once we tackle all those issues, we'll move into the discharge med-rec process. So we have worked for a while in medication reconciliation. So I look forward to working with all of you. I know I'm working directly with Dr. McIntosh, of course, with Dr. Chouinard. She didn't know when I came here that her future partner was coming, but but I'm here to support her in everything and anything I can to allow her to make her job easier. Anyway, I'm going to stop there and thank you for inviting me.
Thank you, Dr. Munoz-Price, for that wonderful overview. And what we're going to be talking today echoes what you said about the importance of medication history and reconciliation and it being on a continuum of care. So my part is I'm going to delve deeper into VCU health system safety reporting, as well as some trends. And then we'll present a case, Dr. Miller will present a case that really exemplifies what we're talking about here and discusses the complexities and challenges of medication history and medication reconciliation. So this first slide is the total VCU health safety event reports for the Department of Internal Medicine from December 2021 to February 2022. You may ask why it starts in December. Well, our data is from when we underwent our EPIC EMR transition. So you can see, and we have an arrow there, that falls and medication-related events are a majority of our safety events. And we're going to tackle today, as much as we can in this hour, medication safety events. Can you forward, please? So this slide shows who in our system are putting a majority of our reports in. You can see that it's our nursing partners who are putting a majority of our reports in. I will say, I think we all will say that in the last few years, providers have been putting in more reports. We've been seeing an increased number of reports from providers, and we hope to see that increase continue. And that's because we all have to remember that the reason these safety event reports are important is that it allows us to look at system-based processes that we can improve to minimize events in the future. So really looking at the system for that. Okay, so I want to go through some statistics. WHO statistics. So medication errors cause at least one death every day and injure approximately 1.3 million people annually in the US alone. I mean, those are staggering numbers to think about. Globally, the cost associated with medication errors has been estimated at 42 billion annually, or almost 1% of total global health. Both healthcare workers and patients can make mistakes that result in severe harm, such as ordering, prescribing, dispensing, preparing, administrating, or consuming the wrong medication or the wrong dose and at the wrong time. But all of these errors are potentially avoidable. Preventing errors and the harm that results requires putting systems and processes in place to ensure that the right patient receives the right medication at the right dose, via the right route, at the right time. And this is a focus for our health system, as you heard from Dr. Munoz-Price. So the WHO launched a global initiative to reduce medication-related errors in 2017. Their goal was to reduce medication errors by 50% in 5 years. So these were the following are the key factors that the WHO wanted to address. And those are medications with a high risk of harm if used improperly. High-risk medications include anticoagulation medication, diabetic medications, antihypertensives, anti-epileptic medications, immunosuppression medications. Patients who take multiple medications for different diseases and conditions, and especially patients going through transitions of care, from the outpatient to the inpatient world, from the ICU to the floor, or from the floor to the ICU, from inpatient to discharge if they're going home, if they're going to a facility. These are all key factors to look at. So to start off, really talk about our presentation, there are two definitions that are important for us to discuss. One is, what is a best possible medication history? And you'll hear that throughout our talk today. It's an accurate and complete list, or as close as possible, of medications that a patient is taking. It also includes information related to medicine allergies and adverse drug reactions. It's crucial foundation in medication reconciliation. So you get the history, and then we talk about medication reconciliation. So what is that? It involves formal and informal processes that involve the comprehensive evaluation of a patient's medications during each transition of care and with any change in therapy. It is complex. There are challenges which we'll discuss, and studies have shown up to 91% of medication reconciliation errors are clinically significant, and that 1 to 2% are serious or potentially life-threatening. So just a little schematic about the best possible medication history. What does it include? Well, it's more comprehensive than a routine medication history. It's a systematic process for interviewing the patient and the family. And it involves a reviewing of at least one other reliable source of information. So looking at a medication database, looking at lists, looking at actual patient medication bottles, contacting a pharmacy to obtain and verify medications prescribed and non-prescribed. The Institute for Healthcare Improvement has really described 3 steps for medication reconciliation. Verification, making sure you collect the right medication history. Clarification, ensuring that you have the right medications, the right doses, the right schedule of those medications, and then reconciliation and documentation of changes in the orders to really reflect the correct, most accurate medication list. So more about the scope of the problem. Up to 54% of patients experience unintentional medication discrepancies upon admission to acute care hospitals. 40% occur at the time of discharge, where a medication is omitted, and a medication is added that you might have thought a patient was actually taking but wasn't. A different dose of a medication, a different frequency, or a different medication within the same class. So prescribing Coreg instead of metoprolol for your beta blocker is an example. So what are the challenges of performing an accurate medication reconciliation? Well, there's a lot. And I'm going to highlight a few that I think are important to highlight because they will be reflected in our case that Dr. Miller is going to present shortly. So challenges include patients may be unfamiliar with their medications. We see this so often where a patient doesn't know what medications they're taking, or if you ask them if they're taking medications, they say yes, when in reality they may not be. Lack of integrated records across the continuum. Patients here can be seen at a hospital one day and another hospital another day. Available information may be incomplete, out of date, or conflicting. So these are all challenges that play a role in the case that we're going to discuss. Like I said, lots of challenges, and that's why medication reconciliation is not easy to recognize the complexity of it. So this is an illustration I think is really good. It shows the overview of medication reconciliation. It starts with home and then ends with discharge. So it's important to get the best possible medication history. What are your sources? You should really get at least 2 sources to confirm a patient's medication. You get it from the patient. Sometimes their family, if a patient is intubated, they can't speak, you talk to their family. They may have a list. There may be a database, a government medication database that you could use, and then prior records. Once you feel like you've gotten the best possible medication history, it's then important to put that into effect while they're in the hospital in the acute care setting. And then the next step, the continuum of care, is that you want the best possible medication discharge plan. And that is supposed to reflect the accurate medications, the accurate prescriptions. And the important thing is that should be reflected in the discharge summary to providers the patient will be seeing going forward, and also to the patient. They need to understand what medications they should be taking and when, and really should understand why they're taking it as much as possible. And if the patient can't understand, then a family member if possible. So this is our case review. I'm going to turn it over to Dr. Miller.
Thank you. So this case is one that was a serious safety event, and it talks about and shows some of the challenges associated with obtaining a medication history. So this is a 72-year-old male who has multiple medical problems, who presented to the emergency department. He had increasing edema and worsening left foot changes and ulcers. He was ultimately admitted to the medicine service for presumed congestive heart failure exacerbation and a diabetic left foot ulcer. His medical history is described there. He has coronary artery disease, peripheral arterial disease, atrial fibrillation, COPD, diabetes. Also of note, he had a history of tongue cancer and had resection in 2014, and he did receive care for that here at ECU. His vital signs are listed below. They are significant for hypoxemia on room air with an oxygen saturation of 86%. Physical exam, cardiovascular exam consistent with history of atrial fibrillation. He has crackles in his lungs on auscultation, he has edema, and an ulcer on his left lower extremity. Lab work and imaging was mostly unrevealing except for an elevated BNP, and CT of the chest was negative for pulmonary embolism, but did show bilateral pleural effusions and right middle lobe collapse. A timeline of some of the events. At 14:07, the patient arrived to the ED. This actually was on a Friday, just to give you some context here. And at 1500, there was a Bravo alert called because an EKG was done. And there was some concern for some ST depression. The CCU team came down, evaluated with a bedside echo. Cardiac enzymes were initially negative, and this was downgraded as patient did not have any chest pain or wall motion abnormalities and had preserved ejection fraction on echo. Further workup was obtained, including labs and imaging. And just before 7 p.m. on that Friday, an ED to ED handoff was obtained. Around that time, the patient was also noted to have heart rates in the 30s. He was hemodynamically stable, and it was listed that he was asymptomatic in the ED to ED sign-out. It is unclear if this information, however, was handed off to the accepting medicine team, as the referral for admission to medicine was placed later at around 7:30 p.m. This patient was ultimately admitted by the cross coverage and the night medicine team. The history was obtained, including the medication history from the patient alone at around 10 p.m. that evening. Outpatient medications were documented in the ED note in the admission H&P. Also of note, the patient had been seen at a VCU clinic one day prior. This is the medication list listed below that shows patient's medications. Unfortunately, this was actually from a prior visit in 2014 when the patient was seen for the tongue cancer. The admit note mentions to continue patient's dose of Coreg. And as you can see there in the list, the Coreg dose was 15 milligrams twice a day. Overnight, the patient's heart rate ranged from 56 to 80 beats per minute. And there also was some concern that about patient's ability to complete the medication list. But due to the time of day and the weekend, there was no pharmacy present to assist with obtaining collateral medication history. It was too late really to reach out to family, although team tried. Also, one thing to note, when the patient went for that clinic visit one day prior to presentation to ED, there were staffing problems at the outpatient clinic, and staff that usually go through medications with patient was not present that day. So going back to our timeline, the patient had been admitted around 10 p.m. The Coreg order for 50 milligrams twice a day was ordered and verified by the pharmacy. The patient received that dose of Coreg at 10:40 the following day, which would have been a Saturday. Around 1 p.m., there was a rapid response called. It was noted on telemetry that the patient had heart rates in the low 30s and was having pauses of 5 to 7 seconds. Although the patient remained hemodynamically stable, he was noted to have worsening mental status. Glucagon was administered and the ICU was consulted and the patient was transferred to the KQ. During this hospital course, the patient did receive additional glucagon, received calcium, and ultimately required a dopamine infusion due to symptomatic bradycardia. The Coreg was held, and the patient was able to be weaned off the dopamine infusion. Upon further review, using medication external field history, also was noted that the patient had been discharged from a local hospital here in Richmond that had a separate EMR. The patient's home dose of Coreg was actually 3.125 milligrams twice a day. And upon further investigation, the patient was also taken to Johnson. Again, this was a serious safety event, and after analysis, the root cause was summarized as follows. Despite us having a safety culture valuing medication reconciliation as a primary safety function at all phases of care, It's incompletely integrated and requires more support. There has also been many other serious safety events, both in the inpatient and outpatient arenas, related to this topic. So this case really brings forth a lot of challenges. The patient received care from several providers from different electronic medical records that didn't talk to one another. There was an outdated medication history from a prior clinic visit. There were multiple staffing challenges, including outpatient and inpatient, also complicated by the time of day that the patient presented and was admitted. That really did not allow for timely best possible medication history. The patient, although he tried, he was unsure of his medications and confirmed these medications with doses on admission. And due to the time of day, there was also no family support present at the time of admission, and there was difficulty in getting in touch with the next of kin to try to verify some of these medications. So you can see a lot of the challenges that we face taking care of patients and trying to get this best possible medication history. Both Dr. Bhardwaj and myself work in ICUs, and we also see a lot of challenges in our environments as well. We also reached out to some of our ICU pharmacists, Dr. Brittany Hardak and Dr. Reed, our MRICU pharmacists, and they provided some additional insightful information that I'd like to share with the group. Some of the challenges that they noticed is the EPIC transition, specifically the complexity of the process of medication reconciliation in EPIC. And really there's a need for standard expectations and process with increased education. Another thing that we see in the ICU is I try to identify the patient. Many of our patients are under trauma names or other names, and it doesn't have their correct name and date of birth. Trying to find what kind of medications and even their allergies can be very challenging. Identifying a family member. COVID impacts, including visitor restrictions, less folks around that actually have the patient's medication bottles, another area that we can try to verify medications. So there's many challenges, and particularly high risk medications as listed there. And then a big one is the weekends, evenings, and nights, and staffing challenges with that. So with that, I'm going to turn things over to Dr. Zolas, who's going to talk to us about a great initiative here at BCU. And we're going to start talking about systems-based solutions. Dr. Zolas will be talking about pharmacy-led medication history.
All right, well, thank you. The first thing I want to talk about is our current state of our pharmacy-led med history service. Pharmacy sees approximately about 30 to 40% of all adult admitted patients. It's equivalent to anywhere from 1,000 to 1,200 per month. Right now, we have 7 full-time pharmacists and 1 part-time med history technician. That has evolved over time. We started with 1 tech and 2 pharmacists, and we had more technicians even earlier, but there's pretty high turnover with these positions. And currently our coverage, we are Monday through Friday only. And that's really from 5:30 till 6 p.m. In certain areas of the hospital as well. Now we do not have weekend coverage, but of course that is something that is highly desirable and brought up even by the patient case. We do have a consult service that has recently started, which we'll elaborate on. And the areas that we cover include the peri-surgical patients in GB5, and that's the one that starts earlier, around 5:30 till 2 p.m. And those are patients who are going to be admitted after the procedure that we're aware of. We also are in the emergency department, of course, and we are in there usually or approximately 9:30 till 6 p.m. We also comb through patients on hospital floors. So those patients that have been directly admitted, or we see a or overnight admission, or we see just something that just doesn't look right when we compare to some of our resources, which I'll show. We'll go and try to speak with those patients. And then 2 of our full-time pharmacists are actually designated for a role in the outpatient setting in the PACE clinic. So they reached out to us to try to get pharmacists to go over home medications even prior to their procedure up to a month in advance for the procedure. So a little about our med history consult. You can now go into Epic and type in an order, a medication history consult. And with this consult, you will get our attention, and you can even put a priority and add specific comments if there is a certain medication that you'd like us to really dive into, try to figure out, or if that's definite focus of the reason why you're putting in the consult. We, as a team, make our med history consults a priority for the hospital, and we will get to them as soon as possible. Now, of course, if one is placed late at night, we won't be here. We'll get to it first thing in the morning. And of course, if it's placed over the weekend, unfortunately, we can't get to it until Monday morning. But it is the first thing that we look at and try to complete. So keep that in mind. A little bit about how our best medication history can be done. This is what our service has found to work and to get the best information. We start by doing a lot of pre-interview workup, and I'll show you some of those sources that we use that are available to us. And then once we have all that information available, we'll go and conduct the patient interview or review the medication list from the facility if they came from one. We'll use the pre-interview workup to help guide that interview and to clarify any discrepancies we find, while we're interviewing with the patient. And then I also want to mention, we always ask open-ended questions as much as possible to allow them to provide the information instead of giving them the information for them to say yes, no, which can mislead us. And then lastly, we'll update our prior to admission med list in Epic and make sure there is a lot of attention to detail because a lot of errors can occur transcribing what you have into Epic. So some of the sources of information that we use here are some. Obviously, a patient interview. So we will put or note the location of the patient at the time we're trying to interview, so the ED or on the floors or in GV5. Of course, they may be poor historians. They may not be able to be interviewed. And so we use other information as well. So we have something called dispense report or external prescription history, as well as the PMP, which I'll highlight. We talk to family caregivers as well to get information or clarify. Many times it's a family member who actually manages the home medications. If any patient brings in a list, that's always helpful, but I will also highlight some of the pitfalls with those med lists, as well as the medication bottles that they bring at bedside. If there are further questions that need to be answered after looking at the external prescription history or dispense report, we'll even call the pharmacy that they say they fill at to try to get some more information and clarify certain things. And then also we will call a patient's PCP office or a clinic to try to get a med list from them as well. And we will note in our clinical notes where who we call and the phone number. And lastly, the MAR or a med list from an outside facility, whether or not we had used that to obtain this information. We stress that you have to, or you should, review at least one other reliable source of information. So yes, you can interview the patient, but I will tell you that many patients, because of the setting that they're in, they oftentimes do not report accurate information and can be highly unreliable. So having that second source is very, very helpful to compare what you get from an interview. So some of you may know, some of you may not, and I know that all of us have different views of Epic, but if you can find it or have found it, you'll know about the dispense report in Epic. And what this dispense report is, it is community-filled history provided by a company called SureScripts. And how you can find that is the quickest way is if there's an envelope next to the patient's name in the top left corner of their profile. You can open up that and it will bring you to the reconcile outside medications, then go to medications and then click the link for dispense report. Now, if you don't have that envelope, it's because they are new patients, they don't have any outside records, or we have also noticed and are still trying to figure out if that, sometimes it's not available because someone has already completed a med rec and it may disappear, that envelope, but you can still get to it. It just, you need to go to the Reconcile Outside Information tab on your own, and then go to the medications dispense report. Now, there are also some notable issues with dispense report. Obviously, they will not be able to connect a trauma name to a fill history. Patients from correctional facilities may not or will not show their fill history in the dispense report. Sometimes patients from skilled nursing facilities, long-term care centers will show, and that's because their insurance information shows, because SureScripts gets this information from pharmacies who are volunteering, they entered into this and provide that information, or it comes from the insurance company, the PBMs provide that information. So sometimes you'll get it for patients who reside in a skilled nursing facility or a long-term care center. Also, some pharmacies don't participate. So, for example, many Kroger does not, but you may still find it because their insurance provides that information. A lot of independent pharmacies don't show up as well. Cash pay prescriptions don't show up. Methadone clinics and other specialty medications will also not show up under the dispense report, so keep that in mind. We do utilize the PMP through Epic, and this is a great tool sometimes, because many times if they have no fill history or dispense report, you can maybe use this to be a detective and figure out where they fill a couple controlled substances, and then call that pharmacy to obtain any other information about their home meds. So utilize this as well. As far as medication lists and bottles, I will tell you that a lot of lists from outside hospitals are highly inaccurate. They probably are experiencing the same issues we are having as a hospital system, where it is an inconsistent process of obtaining an accurate medication history and updating that med list. So keep that in mind. We've also found that even though clinics and PCP offices will give you a med list, it can be also inaccurate from them as well. They also have lists where it can just be a documented med instead of a prescribed med by that provider. And therefore it could be inaccurately documented on their side and then given to us. When you have medication bottles, I always stress that you want to go through those bottles with the patient or caregiver. Because oftentimes they will tell you, oh, actually, I don't really take that one, or, that one it's dropped down to one tablet once a day instead of twice a day. So you get a lot of information going through one bottle at a time. In addition, while I'm doing this, you want to also, I also check the fill dates of the bottles and the number of tablets or capsules in them to address compliance. Apologize, the equal sign there is not lined up, but medication administration records are also very important document to have when they come from facilities, from skilled nursing facilities, correctional centers. And I would use this list to update their medication list in our system. This is what they are on currently. And I want to show you an example of a MAR, because many don't know how to read this appropriately. There's a lot of information on here. I stress that you want to make sure you have the right month of a MAR. Oftentimes in the turn of the month, you get an older one. You also want to make sure you have all the pages of a MAR. Many times they'll come over with a copy or a fax of just the odd numbers, because it was a double-sided packet of information. You'll have certain symbols under the medication administration portion, so the nurse's initials, but then they'll have like an A or an N or R, which are for absent, refused, held, no-show, and that can help address compliance. In addition, you can see that on that top one where there's a lot of grayed out boxes, that was only a once dose. So therefore, that's not an appropriate med to really put on their med list, because that's just a one-time dose, and that's not necessarily what they're taking every day. They also have allergies, of course, on the MAR. Unfortunately, though, they don't show the specific reaction to them. I do want to mention this part about mark as reviewed in Epic. Many of you may not know, but when you enter in and address all the medications, you want to hit the med list status to what's appropriate. There's, pharmacy, provider, or RN complete, and mark as review, because what that does is it helps keep track of the history of this list for this encounter. And if you make changes without marking as review, there's, at least in my knowledge right now, there's not a good way to track why had something been changed or removed, and so, or who had done it and at what time. So marking as reviewed is very important to help maybe the provider after you to figure out, what changes and why, possibly why the changes were made. And I do want to say that this is not the same as a reconciliation. This is a separate task to an actual admission reconciliation. We do write clinical notes, and here is for all the patients pharmacy sees. And here is an example of a note. We include the allergies into our note, as well as those resources that I had mentioned before. We'll put which pharmacy we called. We'll put the family member we may have spoken with. If it is permanent information, we'll say what did they take prior to arriving to the hospital, so that way they will avoid getting a double dose of something for the day. And then we'll incorporate the medications that we had just updated, the list that we just updated, and that will also include any compliance notes. Here in this example, they show up in blue. And then further down, we'll put in their preferred pharmacy. And what we've been doing lately also is putting what changes did we make to that list. And that way you can look to see why or something had been removed. And that can provide further information for any healthcare professional looking into the chart. So as mentioned, there are future initiatives. We are collaborating with the Medication Safety Committee, implementing improvements on this process. We are looking at updating the job aid for medication reconciliation, and a lot of different areas, pharmacy, nursing providers, in both the ambulatory and inpatient arenas are working to help define the roles and expectations for this process, because it is a very extensive process and does take a lot of effort and time.
Thank you very much. Happy to answer any questions or comments that the group has.
So Dr. Carter asks, is a medication history consult only available in the inpatient environment, or can it be used in the outpatient environment?
Currently, it's only available in the inpatient environment.
I was just telling Dr. Syme that unfortunately, this is such a complex process. Physicians are, I include myself in this bucket, we are probably the worst ones at doing
Here's what
it.
I found.
Oh, my watch is talking to me. And the clinical pharmacists are just amazing. I mean, it is a very challenging task, and the truth of what that medication list is it's so difficult to ascertain. So here's a question for the panelists. Given that the hospital does not have unlimited resources, is there a way that we could stratify which patients upon admission should certainly get clinical pharmacists to evaluate them independently of a consult being placed?
Sure. Thanks. That's a great question. One of the things we're very fortunate in the ICU is to also have our pharmacists around with us. So they do a lot of work behind the scenes to also help as well. It's just some of this is related to how much time there is into the day and to the resources. But I think that would be a great opportunity. Would love to also hear from individuals at other areas, because I don't believe that there's actually pharmacy support for all of our inpatient areas, and I'm not quite sure about our outpatient areas.
I think I'd love to, in my ideal state, I'd love to see patients that are on those high-risk medications. And we've tried to do some of that in the past and recognize that we have lots of resource limitations, but those high-risk medications, so any opiates, any benzos, insulin, anticoagulants, I think those patients definitely need a pharmacist's eye, at least in my view. And then any patient that is on multiple medications, and that's 90% of our patients on internal medicine, but if they're on, 5 or more kind of critical medicines, I think those are the ones that should get an additional eye.
And maybe something to add to that would be those patients that are registered under different names, like the trauma names, or just flagging some of those high-risk medications. The hospital did just release a list of some of our top 10 for the high-risk medications as well. So maybe flagging those as well as a patient population at really high risk.
I think the other group I think that's at higher risk are the elderly who are frequently on multiple medications, but also much more likely to get toxicity from them.
No, yeah, thank you. Again, I am making sure that all the resources that we can provide to fix this problem or improve it is going to be allocated accordingly. So I will push as much as I can. It is not my wallet. Otherwise, I will open it and invest it. But I will push it as much as I can.
And we appreciate that very much. Are there any other questions? So Dr. Mayer says, it seems that a national program that all pharmacies across the US would be obligated to input any medication dispensed would be ideal. Sounds like it would require all medical providers to make this need known at a Congress or national level. I think we all agree.
Yeah.
Yeah, I could say, doing this job without just the SureScripts information would be, gosh, an impossible task in my opinion. So just having that is already a step forward, but yes, that would be incredible.
Great point. Thank you.
Yeah, excellent.
Well, thank you all for this really eye-opening presentation. I learned a lot, and I learned how inadequate my own practices despite attention and work. So I think it really just sets the stage for how important this is and how complex it is, even for folks that do this frequently. I'd love to thank Dr. Munoz-Price for her words and her commitment to this work. And of course, Dr. Miller, Dr. Bhardwaj, and Dr. Zolas for really highlighting this work. And thank you all for the comments and questions from the audience. Dr. San, you're on mute.
I was thanking you, Dr. McIntosh, for putting it all together.
Thank you.
Thank you, everybody. Have a great day.